This is Selma Schimmel for the Group Room at the ESMO 2012 Congress happening now in Vienna. So pleased to be joined by Professor Jamie Pratt, who is Chair of Pathology at the Sant Pau Hospital in Barcelona, Spain. We're going to talk to you now about your talk and what are the insights that we should know about in ovarian cancer pathology.
I think that the essential thing is to begin at the beginning. I mean, from the pathology, conventional pathology. And that was the way I presented my talk. I said that 40 years ago, we learned that ovarian cancers, when I say cancers, I refer to malignant epithelial tumors, okay? Carcinomas. Ovarian carcinomas were classified depending upon the cell type, And the cells were, tumor cells, similar to those found in the fallopian tube, not in the ovary. Cells similar to those found in the endometrium, not in the ovary. Cells similar to found in the endocervix, not in the ovary. And you would say, well, how come ovarian tumors are composed of cells not normally appearing in the ovary? That's right. That's a question we had for many years. And we used to answer that question, say, well, during neoplasia, this change of the peritoneal cells occurs. And it happens that the ovary, lined by the peritoneum, is nearby the Müllerian duct, where the fallopian tubes, the uterus, and the cervix and proximal vagina develops. So these Müllerian ducts fuse in the center, have nothing to do with the ovary. The ovary is nearby, but is lined by the peritoneum, and the Müllerian duct is an invagination of that peritoneum. And it used to be given as an explanation for this question that during carcinogenesis, during development of the tumor, the surface epithelial of the cells of the ovary will become metaplastic and mimic those of the fallopian tube, the endometrium, the cervix. And so we have tumors with cells resembling those of the fallopian tube, of the endometrium, the ovary.
Professor Pratt, how is it that the peritoneum and the ovarian tissue are really so similar, and it's so difficult to distinguish if a woman has primary ovarian or primary peritoneal cancer?
The surface of the ovary, perhaps undergoing this metaplastic change and during neoplasia, the fallopian tube epithelium and the pelvic peritoneum all may develop precursor lesions and subsequently tumor, high-grade serous tumor, exactly identical to the conventional high-grade serous carcinoma that we very often found metastatic, not in situ, we found metastatic in the omentum, in the peritoneum, in the abdominal peritoneum.
The distinguishing factor between a high-grade carcinoma and a low-grade carcinoma.
Let me emphasize that when I say ovarian cancer, I'm referring to high-grade serous carcinoma. That is BRCA p53 and good response, not all, but most of them, to platinum and Taxol, okay? Then I have a low-grade serous, also with cells simulating those of the fallopian tube, but low-grade. This tumor has nothing to do with all I've said about the high-grade serous. No BRCA, no breast, ovary, no precursor, no p53 signature, no p53, no BRCA. It goes through different pathways, you see? And this is a tumor of the ovary, an ovarian tumor, which follows a lesion, a tumor, that is known as borderline serous tumor, serous borderline tumor, which is a perfect term to describe a tumor that arises in the ovary, but may also arise in the peritoneum, but often in the ovary. The cells are similar to those of the fallopian tube, but this tumor does not invade, you see, is prepared for not invading. So could it be called carcinoma in situ? Or, well, I wouldn't call it carcinoma because most of them are benign. But you see, nothing is 100% in this life. So these borderline tumors, which are borderline morphologically, clinically, and biologically, are benign in over 90% of the cases. But sometimes, the tumors grow outside and pieces of tumor fall in the peritoneum. These implants go nowhere, they burn out. But in small percentage of cases, they make progression into carcinoma. They invade. And the invasion is small and it's not it doesn't mean much, it's micro-invasion. But when it goes beyond micro-invasion, then you have low-grade serous carcinoma, which is coming from a borderline, and it has a tumor cell without P53, without BRCA. It goes through MAP kinase pathway. RAS and RAF mutations are the common. And then this tumor progresses slowly, but initially you call it invasive implants. But when you have invasion of the entire peritoneal cavity, you call it low-grade serous carcinoma. And in contrast to the high-grade serous, does not respond to chemotherapy because the cells do not cycle that often, you see. They are very slow-growing tumors, and they are very hard to cure because they do not respond to chemotherapy. So all you can do is just surgery.
What is your hope, your vision, your dream, your desire for the future of pathology, advances, molecular pathology on behalf of these gynecologic cancers?
Oh, I think that the future is to, in all this very complex scenery, to decide, where we are with a, say, high-grade serous carcinoma, the most common. We learn because of BRCA that they have a common root, right? They start with P53 and then BRCA, but then you have genetic chaos or chromosomal, gross chromosomal abnormalities, segments of DNA, are lost and gained, and it's very abnormal genetic chaos. At this point, it's very hard to control the situation because you have very abnormal number of copies of DNA, and that makes a tremendous heterogeneity, and there's no way to play target therapy. You see what I mean? It has to be before that. So my hope would be that before that, before it's too late, we can really control, we can really control, before genetic chaos happens, we can really control the tumor growth.
Genetic chaos, that's a great way of saying it.
Yeah, genetic chaos happens when BRCA and P53 work together.
Thank you so much, Professor Jamie Pratt, Chair of Pathology at Sant Pau Hospital, Barcelona, Spain.
Thank you.